Cameron. Okay, we are going to begin, Cameron. I want to introduce you. How we do in Spanish. Bueno, el doctor Cameron Parsa nos va a hablar esta tarde de tromboembolismo y malformaciones congénitas, del síndrome de Duane a la embriopatía por talidomide. Voy a presentar al doctor Cameron. Entonces, el doctor Cameron estudió medicina en Nueva York y en Francia. Fue estudiante visitante en el Johns Hopkins y en el National Eye Institute. Estudió patología e inmunología oftalmológica. Y también estudió óptica e instrumentación oftálmica con el doctor David Guyton. Hizo su residencia de oftalmología en la Universidad de Nueva York, el View Hospital, y el doctor también hizo neurooftalmología bajo la dirección del doctor William Hoyt y del doctor Craig Hoyt en San Francisco. Hizo oftalmología pediátrica y estrabismo de adulto en el Johns Hopkins Hospital con David Guyton. Capacitado médicos en el área de oftalmología, neurooftalmología, estrabismo pediátrico en Teherán, en Irán. Y en dicho lugar, él fundó la primera división de neurooftalmología. El doctor también estuvo en el Johns Hopkins Hospital trabajando en enfermedades oculares y hereditarias, donde tuvo su formación también. También trabajó en la división de oftalmología pediátrica, estrabismo en adultos, con David Guyton. Tuvo una licencia sabática en el Hospital Nacional de Oftalmología en París. Ha sido investigador visitante en San Francisco y ha tenido muchas publicaciones de alto impacto como el síndrome papilorrenal, la neuropatía óptica isquémica y su relación con el síndrome vítreo papilar. Y hoy nos va a presentar uno de sus grandes trabajos, sus grandes publicaciones. Y le damos la bienvenida al doctor Cameron. Thank you, Cameron, for being with us.
Well, thank you for inviting me and for such a nice introduction, reminding me of things I long ago had to look.
Okay, you can share the screen.
Okay, so I hit this, and then I click on this. Click again.
Mm-hmm.
Okay.
Okay, I will disappear. I will be here.
So do you see everything?
Yes, everything is okay. Perfect.
All right. So I'm going to talk about Duane syndrome, and in so doing, I'm also going to take advantage of the fact that we're also memorializing Bill Hoyt. Musi gave a talk about Bill, and his name is almost synonymous with the field he furthered, so neuro-ophthalmology. And I thought it would be nice to give an example of some things that were influenced by him, not only by his research, but also through his effect on teaching on so many others. So aside from his many accomplishments and almost 300 articles and books, he trained the largest number of neuro-ophthalmology fellows, including Musi, as well as myself and others in the audience. And Bill preferred to think of himself first and foremost as an educator. Himself, he was a trainee of Frank Walsh from 1957 to 1958, and then he immediately joined the faculty at UCSF and devoted himself to full-time academic medicine from that point on. And joining the field when it was still relatively in its infancy, he wrote the third volume of a famous Walsh and Hoyt book with Frank Walsh. And it's hard to see how anybody else could make such an impact on the field because he was in it when really one of the pioneers. As they say, for those who wish to emulate Columbus, Christopher Columbus, you can't discover America twice. So while there are many of the problems that remain in neuro-ophthalmology, they're better defined today, and there still needs a lot to be elucidated. Bill Hoyt trained many fellows, as I just said. In the 1960s, this is the list of the fellows that he had. And then in the 1970s, here. There are a few, Walter J. here, Musi here. There's a long list, and including in the 1980s and well into the 1990s. And that's, you know, I was his last full year fellow. But in the spirit of being a true mentor, he not only trained us during the year of fellowship, but even nurturing us after the fellowship was over. He gave customized attention to each one of his fellows after they left, following up on their research and giving them ideas and introducing them to others in the field very enthusiastically. That's how I met many of the people in the audience today. One of his fellows, Barrett Katz, said, quoting from Shakespeare, and a lot of people find this quotation very apt, that Bill Hoyt is a scholar, a ripe and a good one, exceedingly wise, fair-spoken and persuading, but lofty and sour to those who loved him not, and to those that sought him sweet as summer. So he had a difficult personality at times, but very, very fair. And he also recognized that despite the intellectual stimulation that the field had, or perhaps because of it, there was very little remuneration in this non-surgical subspecialty. And he knew that wouldn't be one of the prime rewards of the field. So he chose as the emblem of neuro-ophthalmologists the kangaroo, because he says the kangaroo is something that has little commercial value, but it's fun to have around. And I have my kangaroo tie somewhere, but I didn't put it on because of coronavirus. Neuro-ophthalmology, we know, has been growing. He helped found the NANOS meeting, and there have been the International Neuro-Ophthalmology meeting that was grew out, and the Neuro-Ophthalmology Society of Australia, many other meetings that go on. And it's recognized as essential to giving high quality care, that it actually saves money because more people know about neuro-ophthalmology, the fewer expensive tests they order. I met Emily at the Walsh meeting in 1997 while I was a fellow with Bill Hoyt, and she was doing a fellowship at that time with Tom Hedges, a Bill Hoyt, former Bill Hoyt fellow, and she, of course, worked with Musi as well. I think she's one of the few people I know who did 2 complete neuro-ophthalmology fellowships with Bill Hoyt fellows. And what she asked me to present today is a demonstration of some of the things I've said about Bill. And so I'll just go into that now. It's about Duane syndrome pathophysiology, how we can go back in order to get ahead a little further. This was published in that article that Emily distributed to you with my colleague, Matthew Robert, whom himself met Bill a few times, but trained with one of Bill Hoyt's fellows, that is Gordon Platt, who was a fellow with Bill from '89 to 1990. So just to go over what Duane syndrome was briefly, it was first, there was one case reported by Stilling in the 19th century and another single case by Turk, but Thomas Duane, Alexander Duane, collected about 40 cases, and he clearly defined it as a limitation of abduction with globe retraction on attempted adduction. And what's sometimes forgotten is that adduction is also limited to some extent as well. They always have a distant point of near convergence. And as you know, it's usually unilateral and isolated and sporadic, often left-sided and more frequent in girls. Here's an example. This person has no strabismus in primary gaze, but on abduction, we see the left eye is limited, and in adduction, the globe retracts, causing the narrowed palpebral fissure. So through surgery, it did not reveal, it was initially believed to be the result of a bifid insertion of the medial rectus muscle, part of the muscle inserting medially and part inserting laterally, temporally, causing this mechanical limitation. And this idea came about because when strabismus surgeons did surgery, they saw there was a very fibrotic lateral rectus muscle. But the fact was, nobody ever really saw this bifid insertion. But it was thought still to be a myogenic etiology. In 1946, so about 40 years after Duane defined this, Matucci provided the first histopathological evidence of a neuroanatomical abnormality. He described that the abducens nerve was missing and that the nucleus of the abducens nerve was hypoplastic. The fasciculus containing the interneurons of the third nerve nucleus were still present, however, but he had not examined the orbital anatomy of this patient, just the brain. About 10 years later, there were electromyographic studies done by Duane in New York, who revealed that the lateral rectus muscle did not receive any innervation during attempted abduction, but it did during attempted adduction. And so by 1964, others, including Huber, had confirmed and elaborated on these findings. Bill Hoyt began to think that this was a neurogenic abnormality with these EMG findings that were present, rather than a myogenic mechanism, despite what was seen as this fibrotic lateral rectus muscle on strabismus surgery. And so when there was a visiting medical student, Harald Nachtigaller, coming from Germany with Bill decided to put together all the findings, autopsy and EMG findings together. And he told Harald, go to the library and find all the available literature on the anatomy of the sixth cranial nerve, and don't come back until you find everything available. I don't have a picture of Harald Nachtigaller, but that's how Bill Hoyt looked in those days. So looking at all the available literature, they found some autopsy studies by Paul Bremer that showed some examples of patients that when the sixth nerve was absent, there were branches of the third cranial nerve that could be seen innervating the lateral rectus muscle. But they didn't have clinical correlation of this. But they thought this could be what's occurring in Duane syndrome. It would explain all the clinical phenomena noted. So they wrote this paper up, and it was rejected by Archives of Ophthalmology, but it was eventually accepted by the American Journal of Ophthalmology. And this was a misinnervation syndrome they described. And what many people don't realize, it was the first time in all of medicine that a misinnervation of any organ had been described or hypothesized. This was in 1965. So there was no yet direct clinical histopathologic evidence to prove that when the abducens nerve was absent, the lateral rectus muscle would receive innervation from the third cranial nerve to produce this clinical phenotype. And it took until 1981, so about 16 years later, that a medical student at Hopkins, Mary Hotchkiss, found a patient who had both Duane syndrome and terminal disease. And she called up one of Bill Hoyt's fellows, Neil Miller, who had taught her about Duane syndrome earlier in the year, and said, we may be able to get a clinical pathologic case. And so this was going to be the proof needed. And so with the great histopathologist, Richard Green, and the neuropathologist, Arthur Clark, they were able to confirm this misinnervation syndrome, and not just one, but eventually two clinical pathologic reports. And this was published in 80 and in 81. And this made both Neil Miller and Bill Hoyt very happy. As for Mary Hotchkiss, the medical student, she got the residency she wanted at Wilmer. And other people were saying, if you have Duane syndrome as a patient, don't go to Johns Hopkins. You may not come out alive. It was very suspicious to others how they got two cases so quickly. But it was because once the oncologists realized how interesting this syndrome was, they identified the second case of a patient with terminal disease and told Neil Miller. There were two other autopsy findings that were independently arrived at, 1983 and 1994, And so you would say, well, that's the end of the story. We know that it's a misinnervation syndrome. But despite this, many strabismologists remained unconvinced that this was the predominant cause of Duane syndrome. They said maybe there's a subtype where it's due to misinnervation, but the lateral rectus muscle looks so unusual to us, we don't think that it's, we still think it's a myogenic cause. But one of the autopsy reports had shown that the muscle was fibrotic wherever it was lacking innervation from even the third cranial nerve. So there were parts of the lateral rectus muscle that had no innervation at all, and that was the fibrotic part. And wherever it was innervated by third cranial nerve, it was muscle. There was still some controversy, especially amongst the pediatric ophthalmologists, that Duane syndrome still had other causes. But by what cause, they didn't say anything. So eventually, MR imaging improved to the point where the abducens nerve might be detected in vivo. And it's particularly just when the sixth nerve exits the pons and before it enters Dorello's canal, that this part is just CSF fluid and with no other soft tissue around it, that it could be detectable by MR imaging. And it was actually another one of Bill Hoyt's fellows, Masuto Hashimoto, who had imaged the fourth cranial nerve in about 1994, who told Bill that it may be possible to detect other cranial nerves using MR imaging. And so, as they say, chance favors prepared minds. And when I was a fellow with Bill, we were visiting the neuroradiology suite at UCSF, and the chief of neuroradiology had mentioned to us that a patient with that syndrome Bill you described years ago, Duane syndrome, she was visiting the hospital and had had a fainting spell and fell, and they were going to do a CT scan on her to rule out any hemorrhage. And we just were surprised at the coincidence in finding, and this is the patient, Sasha Dulac, who's an eye movement specialist from San Diego, who demonstrates for us the Duane syndrome that she had. This is the person who fell. So in straight ahead gaze, nothing. And then when she looks to that side, I already showed these pictures, lack of abduction, and here globe retraction on attempted adduction. So we asked her if we could do an MRI on her in addition to the CT scan and see if we could detect the absence of the abducens nerve. And she told us, yes, as long as you keep my name on the paper too. So we did the imaging here, and we could see on the right side, we could see the abducens nerve leaving the pons, but in none of the sections could we see it on the left side. It was absent on the left side. So we saw, oh, wow, we detect absence of the sixth cranial nerve. So there were 4 autopsy cases, and now 1 MR case. Indeed, Sasha Dulac's name is on the paper here that we published. Now, I know some of the people in the audience know Sasha Dulac. She has a successful career in eye movement disorder. She published this paper with David Z and Jorge recently, and many others. But despite 4 autopsy cases and neuro-ophthalmology cases, instance here, as Craig Hoyt pointed out, I said, this isn't going to convince strabismologists. They think you might have been just lucky finding a subset of Duane syndrome patients that happened not to have sixth nerve present, but it doesn't explain everything. So the notion was passed on to a visitor from Korea, Chongmin Hwang, that it would be ideal to do MR imaging in a series of patients, consecutive patients, to show that this is always the case that they have an absence or abnormal abducens nerve. And so she did that. She went back to Korea, and it was with her colleague, Kim. They imaged a series of patients, and they showed that there was a presence of or absence of the abducens nerve according to the type of Duane's retractor syndrome. So sometimes it was a small abducens nerve or an absent abducens nerve. And it came out in 2005. So one can see that deductive analysis really can produce results. After a century of being described clinically, the neurogenic etiology of Duane syndrome was finally established to the satisfaction of all, and it was unnecessary to develop new hypotheses. The sixth nerve could be absent or hypoplastic, as the original Hoyt-Nachtigaller hypothesis had hypothesized, in order to have this misinnervation of the lateral rectus muscle. And one can see how things take a long time in medicine to develop. You had Alexander Duane describe this in 1905, the first mechanism to explain the findings in 1965, but it took until 2005, a full century, until we had neuroanatomical confirmation. That's pretty slow progress, and it's no wonder we still don't have a cure for cancer, I say. So the remaining question, this is stuff that is published in now 15 years, and the remaining question was, what could give rise to this neurogenic abnormality in the first place? And we're aware of all these genetic investigations that have appeared in the literature describing mutations in CHN1 gene, SALL4, and HOXA1 genes that were associated with a small number of the rare kind of bilateral familial Duane syndrome. As I said, it's usually sporadic and unilateral, but there are some cases where there's a familial pattern seen and they can have bilateral Duane syndrome. Mutations in these genes have been noted in some cases. But the same teams have also published that the vast majority of patients with isolated non-familial Duane syndrome don't have these very same mutations. So, you know, what's going on? It's even hard to explain how genetic mutation that presumably would have an effect on axonal guidance, as they presume in the publications, how could it affect axonal guidance only in the brainstem, not elsewhere? And why are these isolated sporadic cases that we see without genetic mutations, how are they usually unilateral if it's genetic? How are they usually left-sided if it's genetic? And why would it be more frequent in girls? So going back a little further, let's look again at the 1965 Hoyt-Nachtigaller hypothesis. If we look simply at the clinical aspects of Duane syndrome, the lack of any ipsilateral horizontal gaze palsy or contralateral gaze-evoked nystagmus, as we would see in a sixth nerve syndrome, tells us that there has to be persistence of the third cranial nerve interneurons, which is what Matucci saw in 1946, and the cell groups of the paramedian tracts, which prevent nystagmus. As I said, Matucci did see the interneurons in 1946 and commented on them. The paramedian tracts weren't discovered until the 1950s, so he didn't make a comment on that. So in other words, if this is the sixth nerve nucleus, and we have the interneurons that go to the contralateral oculomotor neurons nucleus, we know they're intact because there's no horizontal gaze palsy. And we know they're intact from Matucci's work when he did his autopsy finding. So these interneurons are intact. The paramedian tract cells we know are intact too. These go to the cerebellum. They were described in the 1950s after Matucci's autopsy study. We know they're intact because there's no gaze-evoked nystagmus. If these had been interrupted, we would have nystagmus, which we don't in Duane syndrome. So what does this mean? That means that the site of the insult has to be in this part of the motor neurons of the abducens nerve. The insult can't be here, and it's not involving the nucleus. The nucleus is hypoplastic, we know, but it's still present. So that means whatever is happening in utero to cause this Duane syndrome, it has to be here in the trunk. Now, what could be the insult responsible? Well, there's another phenomenon that reminds us of Duane that could give us clues. That's the benign recurrent sixth nerve palsy of childhood. What's special about that? It's also isolated, it's also sporadic, it's also predominantly left-sided, and it's also more frequently noted in females. So that could be some postnatal equivalent of what's happening in utero to create the congenital Duane syndrome. These are some papers that talk about benign sixth nerve palsy of childhood. And although it's often called benign, many cases nonetheless do leave a residual sixth nerve palsy, paresis, indicating that there's some degree of permanent axonal damage that occurs in these childhood cases. Now, if that's happening after birth, imagine what would happen in utero. Not only would you get anterograde axonal degeneration, but apoptosis and retrograde degeneration with possible disappearance of the sixth nerve trunk. So this would result in an apparent hypoplasia of the sixth nerve nucleus, while permitting the third nerve interneurons for gaze direction and the paramedian tract cells involved in gaze stabilization. In other words, if we have an insult here, we can have disappearance in benign sixth nerve palsy of childhood. We get some damage here and regeneration, possible paresis. But if this were to happen in utero, where things are much more sensitive, we could have disappearance of all these neurons, leaving a hypoplastic sixth nerve nucleus, as the autopsy studies have shown, and leaving intact the neurons, interneurons and paramedian tract cells. And of course, then with this disappeared or hypoplastic sixth nerve trunk that's no longer innervating the lateral rectus muscle, this muscle will send signals, neurotrophic signals, for an offshoot of the oculomotor nerve to come innervate the lateral rectus muscle, as long as the oculomotor nerve hasn't made contact yet with the medial rectus muscle. Once it makes contact, the sheath would prevent any offshoot from occurring. So if we have damage to the lateral, to the abducens nerve, just before oculomotor nerve has made contact with the medial rectus muscle, an offshoot can come here. If we have a hypoplastic abducens nerve that's not totally disappearing, we still may have a branch of the oculomotor nerve come, as well as partly innervated by the sixth nerve lateral rectus muscle. And that would cause the type 2 Duane syndrome, where there is some abduction possible. So it doesn't necessarily involve total loss of the abducens nerve, but hypoplasia may be sufficient. And what we saw in the MR studies is that in type 2 Duane syndrome, you still could pick up an abducens nerve on the MR imaging, but it was hypoplastic. That wasn't noted in the initial reports of 2005, but subsequent letters have pointed that out. So depending on the extent of the initial insult to the sixth cranial nerve, we get various phenotypic variants of Duane syndrome, such as type 1, when the abducens nerve is totally absent, type 2, where it's hypoplastic, or type 3, where it may be absent or hypoplastic. So we've now pinpointed where the insult must occur, to the trunk of the sixth nerve in utero. And the question is, the etiology of this insult. We say it's like sixth nerve palsy of childhood, but occurring in the utero. So what insult could this be in a child that would be isolated, sporadic, and more often left-sided? Well, those are the clues we have to look at. Unilateral, left-sided, and female predominance. So what could be so asymmetric in the head to have this sort of anomaly, man or woman? Well, that gets to the heart of the problem quite literally, because we shouldn't be looking at the head, but at the heart, which is left-sided, of course. Consistently unilateral cephalic phenomena, 2-to-1 left-to-right ratio, like Duane syndrome, has long been noted to occur secondary to emboli originating from the heart. This was noted in the 1950s with calcific emboli from the heart and rheumatic heart disease that have strokes twice as often on the left than on the right. And that's because with the left-sided placement of the heart, the origin of the carotid arteries are different. The right carotid comes off the subclavian, the left carotid comes directly off the aorta. And so emboli that are emerging from the heart, well, if some go in the first bifurcation, it's a 1 in 2 chance to go in the right carotid artery, but at the second bifurcation, it's a direct chance going into the left. And this is true also in utero. When we get close up, we have the bifurcation of the left, right carotid off the subclavian, the left directly off the aorta. And this is true even in the 6-week-old embryo, fetus, 6 weeks. So if we have emboli that are leaving from the heart, first bifurcation, if say 2 emboli go in, only 1 out of the 2 is likely to go into the right carotid. But if we have 2 emboli going into the next bifurcation, well, they're going in directly into the left carotid. And that's why we know that emboli from the heart have twice as much chance going into the left side of the brain than on the right. We know there are 3 kinds of emboli: calcific, cholesterol, and fibrin. We don't get these first 2 in embryos, fetus, but we do get fibrin clots. And they've long been known to be the rule for fetal and perinatal strokes. So there's nothing unusual about having a fibrin clot. That's been well documented in the literature for a while. So we're explaining the 2-to-1 left to right ratio. And it's the fact that women, girls, genetically are predisposed to having thrombosis more than boys, not only because of hormonal factors, but genetically, in order to prevent blood loss from childbirth and menstrual periods, to prevent excessive blood loss. So that's also something known. Women, girls are more prone to developing thrombosis than boys. Again, it's been well established for other neurological problems, fibrin clots called strokes, perinatal strokes, but they never were considered before as a cause for misinnervation syndromes. And again, misinnervation syndromes were never considered before Duane syndrome. It was a first in medicine when Bill proposed this. And perhaps too many people were still thinking of myogenic causes, not to think of this issue. Now, we could say, what happens if fibrin emboli occur not to the trunk of the 6th nerve here outside the pons, but at the fascicular level within the brainstem, here or in the closer to the nucleus, not outside the pons? Well, here there was a paper by Walter J. and Craig Hoyt, abnormal brainstem auditory evoked potentials in patients with Stillings-Duane syndrome. In other words, you could have the auditory nerve involved if the 6th nerve is involved in its fasciculus and also affecting nearby cranial nerves. And as you know, Walter J. was a fellow with Bill Hoyt, I think with Musi maybe, and Craig Hoyt, one of his trainees as well. If you have lesions to other cranial nerves, not just the 6th, you could have other phenomena that occurs if the emboli goes right. And you have congenital crocodile tears, always ipsilateral to Duane syndrome, that were described by David Taylor. Again, another one of Bill Hoyt's fellows, here with his wife Anna, which is, again, a potent indicator to the origin of Duane syndrome. So such associations point to a more proximal fascicular involvement of, say, these fibrin clots within the brainstem that can also cause Duane's associated with other problems. And Michael Brodsky, you know well, he has this in his book, this masterpiece of pediatric neuro-ophthalmology, also a Bill Hoyt Fellow in 1986, and who was the first to consider that perhaps other supposed ocular myopathies, such as congenital fibrosis syndrome, might also be due instead not to fibrosis of the muscle per se, but to a neural misdirection. And he proposed this in 1989, that congenital fibrosis syndrome could also be a misinnervation syndrome. And this was proven to be correct in 2007 by Joe Deemer using high resolution MR imaging, showing that there were abnormalities of the ocular motor nerve. That lack of innervation to certain muscles would cause them to become fibrosed, as in Duane syndrome, and misinnervation to have co-contraction of different muscles normally innervated by the ocular motor nerve. So we see how this idea of misinnervation doesn't extend only to Duane syndrome, but congenital fibrosis syndrome with the third cranial nerve. And in fact, when we look at other misinnervation syndromes we know about, congenital facial palsy, what was unappreciated was that these two are often left-sided and often female predominant. So what about other misinnervation syndromes we recognize now? Congenital ptosis, Marcus-Gunn syndrome. Yes, these are more often on the left side and more often in girls. Should we be so surprised? The possibility of ischemic events and the pathogenesis of the Mebius syndrome, which was a cousin of Duane syndrome with aberrant tear, has long been supported by imaging and necropsy studies that showing calcifications in the brainstem. But these haven't been disputed to have a vascular etiology, leading to the concept of a subclavian artery disruption sequence that was published in several publications. And when they did CT scans, you could see calcifications in the brainstem of these children. But these were more widespread ischemic insults that involved the new nerve nuclei as well. And here, instead of substitutive innervation, you had gaze palsies. So the stated paradox of a vascular disruption causing focal manifestations can be understood either by supposing a zone of vascular susceptibility on the fetal brainstem. That wasn't controversial, and that explains Mebius syndrome. Or what was more overlooked, invoking transient, very focal ischemia from an embolic event affecting the brainstem directly, and then allowing for misinnervation phenomena. And that's, again, where mentioning fibrin clots can be causative. And where would they come from? They could come from the heart if there's a cardiac malformation causing a lot of turbulent flow and thrombi to form in the heart. Or they can come more often from the venous system and migrate to the patent foramen ovale prior to birth, paradoxically migrate through the physiological right to left shunts. And the unilateral left-sided and female predominance of not only Duane syndrome, but congenital ptosis and facial palsy results from the asymmetry in the thoracic vascular position. So here's a table that shows Duane syndrome, yes, left-sided in 72%, congenital ptosis also, jaw winking phenomenon, congenital facial palsy, and female predominant cases. There's only one series of congenital ptosis, and that one it was 44%. So then the next question one should ask oneself, well, what would carotid artery fibrin microemboli that don't lodge within the vasa nervosum of the cranial nerves, what would they cause? Well, if we had some occlusion, say in the level of the carotid artery, we could have persistent trigeminal arteries, known as persistent fetal vasculature, that would exist. And these are known to be twice as often on the left side than on the right. And when we just thinking of persistent trigeminal artery in the persistent fetal vasculature nomenclature, it makes one think of the Edward Jackson lecture given by Mort Goldberg, where he really emphasized persistent fetal vasculature in ophthalmology, and how this was responsible for so many congenital malformations we knew about in ophthalmology, such as persistent hyaloid artery here and congenital cataracts. We have this hyaloid vasculature here, fetal vasculature, that if we have an occlusion might cause, say, some sort of not inferonasal coloboma of the iris. We can imagine what would fibromicroemboli do if they were to lodge at the level of the lamina scleralis in utero, the central retinal artery hyaloid. What would that do? Well, to understand what an occlusion here could do in utero, it's helpful to see what it would do in an adult. And this was a paper with Musi that I helped write with Bill Hoyt, where a patient who had calcific valvular heart disease had a calcific emboli that caused a central retinal artery occlusion in an adult. And this caused her to lose vision. But in the weeks and months that followed, one could see nettle-shaped collateral cilio-retinal arteries that arise from the margin, from the periphery of the disc, resuming flow to the retina periphery. Too late to save vision in the eye, but nonetheless, we see all these cilio-retinal arteries that emerge postnatally because of a complete occlusion of the central retinal artery. And I know you know about these things because Musi and Emily found a few more of these cases that they published as a series. Now, if this same sort of insult were to happen, not with calcific emboli, but say a fibrin clot and the very fast moving scene of an embryo, what we could have is the absence of the central retinal artery and all these cilio-retinal arteries that emerge in what we call the morning glory anomaly optic disc. And in fact, when we look at the phenomena of these anomalies, morning glory anomaly or unilateral congenital cataracts due to persistent fetal vasculature, we notice they're more often on the left than on the right, and more often in females, including, as I said, the persistent trigeminal artery and porencephalic cavities, which are well established to be caused by fibrin emboli prenatally or in the perinatal unit. So all these things that we know about, not only misinnervation syndromes, but congenital anomalies in the territory of the carotid arteries are always twice as often on the left than on the right, and more frequent in females. And that includes morning glory anomaly, as I just talked about. So then the next question you may ask is, well, okay, fibrin emboli can go in the vasonervosum of nerves. It can block larger arteries. What about emboli that don't even end up cephalically, that don't go in the carotid arteries or the vertebral arteries, they just go elsewhere in the body? What effect would that produce? Well, we know certain things that seemingly remain unexplained. We see this child here, we see these pictures here, and now I think I know what you're thinking of, this phacomelia. This, of course, was part of the epidemic of malformations caused by the drug thalidomide in the 60s and 70s that was kept out of the US market because of skepticism from this FDA researcher based on a neuropathy that she thought would happen. But it bought enough time so that people could see that this really had grave consequences, this drug, and all sorts of prostheses can be made to compensate. But so why talk about thalidomide in this setting? Well, thalidomide, as you know from work by Marilyn Miller looking at registries in Scandinavia, is associated with producing Duane syndrome. When it's taken at the 6th week of pregnancy, thalidomide causes Duane syndrome. And you'd say, well, how would thalidomide do this? That's always been a question until now. And the question is answered by the fact that when thalidomide was given later for other causes, not morning sickness, it's been found to be a very potent thrombogenic agent. And so patients who receive thalidomide, now they have to be given blood thinners because they get it's a thrombogenic agent and a very potent one at that. So that's the answer to a nearly 60-year-old mystery. The multiple and varied symptoms of thalidomide embryopathy are simply the result of the emboli it causes during a critical period of gestation, when the blood vessels precede tissue and organ development. If you occlude a blood vessel before there's been tissue that's grown around it, that tissue will never grow. If the tissue has already grown and you block a blood vessel, the collaterals can form, and you will not lose the limb or the organ. But at the critical period, when it's only a blood vessel, occluding it then will cause you not to develop that limb. So the risk factors for the development of emboli in utero are something we have to look at, and the risk factors, we know about them. In fact, they're all the things we say we shouldn't do during pregnancy. Risk factors can be medications. Thalidomide isn't the only one. It can be malnutrition, of course, dehydration, that causes a lot of venous emboli, alcohol, dehydration also, infections, trauma, ionizing radiation, antiphospholipid syndrome, which maybe 2% of nubile females have, but if you, in its complete form, but in incomplete forms, up to 15% of women in Europe have some degree of antiphospholipid syndrome. And there are other autoimmune disorders as well. And these environmental or autoimmune disorders that predispose to thrombogenesis will have synergistic effects to create emboli and thrombus if they're predisposing genetic factors, such as factor V Leiden deficiency, which affects 5% of the population, prothrombin deficiency, and others. So we're really narrowing in on microemboli in utero. They have to be causing some defects. How could they not be? We know they exist. We know what causes them. Explain how they could exist without making some issues. And we go back. What about the genetic associations for those rare familial cases of Duane syndrome that were described? Well, the mutations in those genes that exist for those rare familial cases, they don't predispose to anomalies of axonal guidance. That's simply a presumption of the authors of those papers based on the fact that Duane syndrome is recognized as being a misinnervation syndrome. They never showed that it causes axonal guidance issues, let alone just in the brainstem or on the right. But what they do, and this is a fact, these mutations do predispose individuals to thrombogenesis. In fact, that's the sine qua non of the HOXA1. It causes massive cardiovascular abnormalities. And patients who have these mutations, they don't just have Duane syndrome. Duane syndrome is the least of their problems. They have all sorts of problems with multiple congenital malformations. So to sum up, the practical consequences of all this are easy to envision. The screening and identification of thrombogenic risk factors assists in the prevention of such malformations throughout the body. And so this Duane story, I think, demonstrates a lot of what Bill Hoyt emphasized. Collaborative teaching, having a whole group of fellows and fellows of fellows interested in issues and asking questions, framing them to deduce explanations, not be afraid to put forth hypotheses, but which can then direct others to corroborate them, like the autopsy studies or the MR imaging. Craig Hoyt was kind enough to write an editorial to encourage others to go look forth for more proof of this microemboli hypothesis for Duane syndrome and others. And I think those who trained with Bill know exactly what I'm talking about. He supported us, we supported him, and this is a gathering of his fellows at his 70th birthday festschrift in San Francisco. Bill, by the way, told me it was Musi here that taught him to think of his fellows as children, each with their own weaknesses and their own strengths, and to tailor the teaching accordingly. And it was Musi who wrote this very nice memorial for Bill as a mentor and a wise person who could deduce things from facts that don't seem directly relevant. Neil Miller, who wrote another obituary for Bill, and also Walter J. In the Journal of Neurophagy. I also wrote something on the life and times of Bill Hoyt that go through some of the events around his life and the training that he gave to so many of us. Here he is on the second visit to the axis of evil country, Iran, to support and promote one of our fellows who did a fellowship with us, as well as with Neil Miller, Mustafa Sandri. And all I can say is thank you, Bill, for teaching us and showing us how to go about these things so well. And that's all I have to say for now.
Cameron, thank you for your kind words. And I remember when you first presented this idea at UNOS, I think in Oxford.
Right.
I was very intrigued. I still am intrigued. I'm still not sure.
But you have to help find the evidence for it.
Well, I'm getting too old for that. Okay.
Thanks.
That was outstanding. Great talk. I have two comments to make. The neurons in the sixth nucleus, the interneurons are glutaminergic. The motor neurons are cholinergic. So even though they live in the same nucleus, they're structurally different. Mm-hmm. This is work of Anja Butler. You can find that. So that, I wonder if that has something to do with these two. Just think about that, because they're basically different. And the second thing is, I can think of right now of patients with multiple sclerosis, women who have a chronic six and never get better. That is not complete paralysis, but they have a phoria that remains forever. I can tell you that I have at least 3 patients with lesions in the fascicle of the 6. So you could wonder if they have had a subclinical event that didn't lead to a complete Duane's, and then, they are more susceptible because all the other attacks that they get in the brain stem seem to get better completely. So that's an interesting point too.
Yeah, I've seen a couple of those patients that come to the strabismus clinic pretty frequently. And like you, I've seen a couple where they just didn't get better. But that could be, direct demyelination and axonal loss from the autoimmune disorder. But maybe some have this benign, so-called benign sixth nerve palsy. What one could do and to detect that, to rule it out, is see if they have patent foramen ovale. I mean, a lot of us have it, and you could do an ultrasound of the heart. If they have it, then maybe it was an embolus. But if they don't have it, they don't have a patent foramen, you could exclude that possibility.
It's interesting because there are women and it's left-sided. That's the problem. Yeah, that's why I caught my attention. Great, thank you.
I think the idea of doing ultrasound for patent foramen ovale is something that probably we should look more at for things where we suspect there could be a ischemic postnatal phenomenon with microemboli, something that's a very focal lesion, like you can get in MS. I mean, I think that's a good example. In MS, we sometimes see such a focal small lesion, and we say, it could be ischemic or it could be MS. Those are our 2 differentials. And if it is ischemic, could it be microemboli? A heart ultrasound a Doppler could tell or help.
¿Algún otro comentario? Some questions, other comments?
Thank you, Cameron.
Cameron, may I ask you or mix a comment and a question? I hadn't the chance to be a Bill Hoyt's fellow, but he visited us twice, in '88 and 2001. When he came in '88, in the first visit to the British hospital, I showed him a patient, very young child, with simultaneous adduction and abduction of both eyes. He gave me the diagnosis right away of a Duane type 4 with the simultaneous misdirection of the third and the sixth on both sides.
Right.
I still see the patient. He is a young boy with a certain university degree today. And back to your words, he has more ill situation on the right than on the left. So maybe there is also a vascular explanation in that. Have you ever seen a fourth Duane type patient?
I don't think I've sometimes you get the same phenotype from people who had type 1 Duane syndrome, and then they recess the medial rectus muscle too much. And then what happens is the innervation of the lateral rectus muscle by the third cranial nerve is it makes a stronger force for divergence than the recessed medial rectus muscle. So it's not a true Duane type 4, but it's called what Jan Polsky calls the ocular splits. When they try to converge, the eyes move apart.
Sure.
But in the type 4, I think Kim and Huang, they published another series of MR images, imaging of patients type 4. And what they found is you have, as you said in 1988, Bill told you, it's the sixth nerve that's absent or hypoplastic, but also the branch subnucleus of the third cranial nerve that goes to the medial rectus muscle that's hypoplastic. So it's rare, it's really rare to get that bilaterally, you know, to have the sixth cranial nerve affected as well as just the branch of the third cranial nerve. So it's possible, but it's rare. So, you know, you had one case and
he gave them the diagnosis.
Yeah, that's pretty good in '88 too, to say that it's a hypoplastic third cranial nerve as well.
He also mentioned the theory was given by a doctor named Van Allen, who was a cousin of the other Van Allen who described the belt.
Wow, the radiation.
Yeah, yeah, sure. Interesting how things mixed over time.
I'll look that up, Van Allen. That's easy to remember.
Yeah, sure. Well, thank you anyways. It was an excellent presentation. Brilliant.
It's good to see you, just even this way.
Dr. Musi, si quiere hablar.
Yes, I was astonished. Yours was a marvelous talk, Cameron.
Thank you.
And also, I thank you for remembering our friend and mentor, Bill Hoyt. Thank you very much.
Thank you for all your teaching. I think Bill Hoyt was so happy that you went back to Venezuela and you taught so many others. I think that made him more happy than anything.
Thank you, Cameron. If somebody has another question, ¿alguien tiene alguna cuestión, una pregunta? Emily, you have a question here. Marcela asked you, you have to follow this patient with the antiphospholipid test or echocardiogram?
Well, I think it's a very good question. Their antiphospholipid syndrome has different degrees. If you have the 3 antibodies present, that's a small percentage of women who have that during pregnancy. But you still can get coagulating effects with 2 or even 1 of the 3 antibodies present. And if you look at any degree of antibody, antiphospholipid antibody for coagulation, it's really 9% of women in childbearing years. It's a large percentage. And what they have found in those who have the complete 3 antibody is present, 85% would have abortions, spontaneous abortions, stillbirths. And by giving heparin or aspirin during the pregnancy, and this has been well studied, the incidence of for normal births, it goes from 15% to 85% normal births. So what they haven't done, and I went with one hospital and it still hasn't been done, but it was in discussion, is look not only at how many stillbirths there are in antiphospholipid syndrome and how many are reduced when heparin, aspirin therapy is given, but the other congenital malformations. How often do they occur in antiphospholipid syndrome? Not just death, but malformations. And how much may they decrease with anticoagulation therapy? That's really, I think, the next step to do. If someone wants to do that study, it was a little difficult to do at the hospital that I had relations with, but that I think would be a very useful study. It goes right in what's being done in medicine anyway in the syndrome, but simply add looking at malformations and not just death. So, you know, what would you do if for the moment, if you know somebody with antiphospholipid syndrome, I would probably talk to the obstetrician and say, is there some way to, you know, reduce thrombosis as much as possible, and take that into account, yeah. And also, one can, if you want to go a step further, is look at factor 5 Leiden deficiency or other things. It may be that the people who are at most risk for having emboli in their fetus are people who have more than one factor. They may have a genetic background as well as antiphospholipid syndrome or other issues. That's
Okay.
probably most likely.
You have the same question, two times the same question. Okay. If somebody has another question or other comments, alguna pregunta, algún otro comentario. Thank you, Cameron, so much. It was wonderful talk.
Thank you for the first Zoom conference.
Okay, was wonderful. Was a wonderful talk. Hope people is happy. You have too many congratulations here. I will send to you. Okay.
Thank you very much. Thank you. And nice to see you, Musi. And I'm glad we wrote that paper together on the nettleship collaterals. It's always given me a lot of ideas.
Thank you.
Oh, hi, Craig.
Okay. Yeah, we are ready. Well, ok, los veo entonces la próxima semana. Doctor, tendremos una presentación de apatia oculomotora. Les estaré enviando el link para la próxima semana con el doctor Guillermo Marroquí. Que tengan buen día. Hasta luego. Bye.
Okay.
Thank you. It was a pleasure to have you with us. Thank you so much.
Bye-bye.
Bye.
Ciao, bye-bye.
Goodbye.
Bye.